Hello, good evening, everyone. Hello, good evening, everyone. Assalamualaikum warahmatullahi wabarakatuh. My name is Dato Dr. Muhammad Hatta. I'm currently the treasurer for MSAT, and I would like to welcome all of you to the MSAT 9th webinar organized by Alpha IVF and Women Specialists. Women Specialists. We're delighted to have you with us today. Before we get started with today's webinar, I'm pleased to share the theme for our annual conference of 2024, which is Looking Within to Grow Beyond. MSAT CME 2024 will take place on the 5th and 6th October 2024 at Sunway Pyramid Convention Center. Our focus this year is on exploring changes big and small, that can improve our daily operation. We'll share more details soon, and I assure you that we have an impressive lineup of both local and international speakers with many engaging topics planned. This conference is a prime opportunity to enhance your knowledge and build valuable connections, and I hope to see all of you there. Next, I want to highlight our upcoming July webinars. On July 11th, we will be featuring a session with Dr. Haris Johar Jodo, consultant gynecologist and fertility specialist at Sanford Kuching, Sarawak, who will discuss the role of progesterone support in IVF. Then, on July 25th, we will host a session with Dr. Tam Seong Wai, consultant obstetrician and gynecologist and head of reproductive medicine unit, ONG, Department Ipoh General Hospital, who will be speaking about personalized luteal phase support, optimizing outcome and improving satisfaction. Registration will open soon on our website. Now, this is the agenda for today. We are pleased to have Mr. Stephen Yap, Senior Geneticist at Alpha IVF and Women Specialist, joining us today to discuss salvaging euploid blastocysts from abnormal fertilized zygotes in IVF via biparental testing and ploidy assessment. While Mr. Stephen is presenting, please feel free to submit your questions in the Q&A box. We'll address them during the Q&A session at the end. Now let me introduce Mr. Stephen. Mr. Stephen has been a senior geneticist at Alpha IVF Women's Children's Specialist, making significant contributions in the field over 10 years. He specializes in implantation genetic testing or PGT, including PGTA, PGTM, and PGTSR, and is proficient in advanced PGT technologies such as NGS, microarray, CGH, and the FISH. He actively participates in numerous local and international scientific conferences, frequently presenting his research on PGT and embryo morphocentricity. Additionally, he is skilled in counseling patients undergoing mosaic embryo transfer and PGT. With that, I present to you Mr. Yap, Mr. Stephen Yap. Thank you.
Oh, sorry. Can you guys hear me? All right. Okay.
Yes.
Okay. Thank you so much, Dr. Hatta, for the kind introduction. My name is Stephen. I am the senior geneticist of Alpha IVF and Women Specialist. First of all, I would like to thank everyone for spending their time here today to attend this webinar, where we will share our insights on salvaging euploid blastocysts from abnormal fertilized zygote using biparental and ploidy assessment. So with that, I will begin the presentation. Let me just share my slide here. Okay, can everyone see the slide?
Yes, we can.
Okay, great. So I will go to presentation then. Okay, so these are the topics that will be covered today. Sorry, we will begin with looking at the differences between normal and abnormal fertilization. Then we will explore some of the mechanism of formation for 3PN or more than 2PN and 1PN embryo. So in this webinar, I will use the word PN to represent the word pronuclei or pronuclear for easier understanding. Then I will also share a retrospective study where we have conducted to assess the chromosomal and body status of blastocysts that were derived from abnormal fertilized zygotes. And I will also then introduce a polyploidy assessment panel that might be useful in assessing the body status of the embryo. And we will end the webinar with a Q&A session. So without further ado, I will begin with a recap on how does normal fertilization occur. So a normal fertilization occurs when you have a sperm that enters the oocyte, and this will continue the meiosis II process of the oocyte. And at the end, you will get a formation of a male and a female PN. And at the same time, you have a second PB that will be formed within the oocyte next to the first PB. And this 2PN will then migrate to the center of the oocyte, as you can see over here. And they will be fused together in a process called syngamy. And after that, the embryo will then undergo their first mitotic division, and this is where you get a 2-cell embryo. So that is how a normal fertilization occurs. In terms of abnormal fertilization, you do not see 2PN during the fertilization. In fact, you see 1, 3, or more PN in a zygote. And there are some instances you see 2 normal size PN, but there are small PNs that appears around it. So these embryos are called 2.X PN, and X here represents the numbers of small PN that you've seen. So if you see 2 small PNs around this 2 normal size PN, then this embryo will be categorized as 2.2 PN, and so on. And abnormal fertilized embryo are usually discarded due to the fact that they are assumed to have abnormal chromosome constitution, be it a single set for haploid or multiple set for polyploid. And transferring this embryo will increase the risk of miscarriage, implantation failure, and hydatidiform ball to develop. So that is generally the differences between the normal and abnormal fertilization of the embryo. So now let's look at some of the mechanism of how does this embryo was formed. So we'll first begin with looking at the mechanism of 3PN or more than 2 embryo. Generally, these are embryos where you have 3 or more than 2 PN, respectively, seen during the fertilization check. So here are some of the examples. Here we have a 3PN zygote where you have 3 equal size PN seen during the fertilization. This is a 2.1 PN. So you can see you have 2 equal size PN here, but you have a smaller PN here appears next to it. So generally, there are 2 mechanisms. The first is diandric triploidy. So diandric here means you have 2 sets of partner chromosome. So the first way that this could happen is you have a oocyte that was fertilized with 2 haploid sperm. And these are commonly seen in IVF insemination where you have 2 sperms that was inseminated into the oocyte. So during the fertilization check, you will see 3 PN and 2 PB, where out of these 3 PN, 2 of them are from paternal and 1 is from maternal sets of chromosome. So during the assessment of the fertilization, you would deem this is an abnormal fertilized embryo. The second way is you have a single sperm that fertilized the oocyte, but this sperm contains diploid sets of chromosome. And these are usually seen in oligozoospermia patients. So during the fertilization check, you will see 2 PN and 2 PB, which is sort of like the same as a normal fertilization embryo. But one of the PN here actually contains a diploid set of paternal chromosome. So by looking at the microscope, you actually can't really distinguish this from a normal fertilized embryo. So the second mechanism that this could happen is digenic triploidy. So just now, diandric means you have 2 paternal sets of chromosome. Digenic here means you have 2 maternal sets of chromosome instead. So again, there are a few ways that this could happen. The first way is what we call non-extrusion of second polar body. So remember during the process of when I explained about normal fertilization, we would expect a second PB to be formed after the PN appears. But in this, so these are usually um, due to the deterioration of the meiotic spindle during the sperm injection, meaning that when you do the ICSI, somehow has already damaged the spindle fibers. So during the fertilization check, you will see 3 PN and 1 PB. But again, this you can actually categorize this as abnormal fertilized embryo during the fertilization check. The second method is endoreplication of the maternal PN. This occurs when you have everything goes well, you have haploid eggs here, you have a haploid sperm. These two were fertilized and you have 2 PN and 2 PB, each are haploid. But somehow or other, something happened. The maternal cells or chromosome duplicate itself without any mitosis or cell division. So for this, because you have already assessed it as a normal fertilized zygote, and if it happens, you actually can't really distinguish it from a normal fertilization. So the third way that this could happen is when you have a giant oocyte here in IVF and this kind of oocyte was fertilized. Usually this kind of giant oocyte contains a diploid set of chromosome. And these oocytes are usually formed due to the oogonium fail to divide, or it could be two oogonia that actually fuse together in a cytoplasmic fusion. So this kind of oocyte appears as two forms. The first form is you have one large first PB here. If a single haploid sperm was used to fertilize this kind of oocyte, you will see as 2 PN and 2 PB. Again, one of the PN contains a diploid set of maternal chromosome, and you also can't distinguish this from a normal fertilization. In the case that the giant oocyte that contains 2 first PB, if you fertilize with a haploid sperm, you will see 3 PN, where 2 of the PNs are from the maternal and 1 is from the father's sets of chromosome. But you also see multiple PBs here. So you have at least 4 PBs that will be formed around this. So fortunately, this can be assessed as an abnormal fertilized zygote. So you probably will not use this for embryo transfer. So generally, those are the mechanism for more than 2 PN embryos. So now let's look at the mechanism for 1 PN embryo instead. So generally, 1 PN embryos are embryos with a single pronuclei that was seen during the fertilization check. So the mechanism, also there are 2 types. The first type is this 1 PN contains only a haploid set of chromosome, meaning we only have half of the human cells of chromosome. Again, there are a few ways that this will happen. The first one is what we have well known as self-activation of the oocyte, which is called parthenogenetic activation of the oocyte without any sperm enters it. So the eggs activate itself to form a PN without any sperm enters. The second way that this will happen is, well, you have a sperm enters the oocyte and it is activated, but instead of 2 PN that was formed, only the female PN is formed here. The male PN did not form. And the third way is the other way around, rather than the female PN, the male PN is formed instead. So that is for haploid sets. The other mechanism is within the PN contains diploid sets of chromosome. So there are 2 ways that this could happen. The first is you have 2 separate PNs formed after the sperm enters, but it is fused together very quickly before we were able to assess. And they form one large PN here, but this one large PN here contains both female and male's genome. The other way is during the formation of the PN, this male and female PNs is incorporated in one large PN. So along the way, you will only see one PN appears, but within this one PN, it actually contains female and male sets of chromosome. So after understanding those mechanisms of this abnormal fertilized zygote, we also need to talk about the timing of the PN formation and breakdown. So generally, the timing of PN formation ranges as early as 3 hours to as late as 20 hours post insemination or injection. And generally, we do the fertilization check for ICSI cases is 16 hours after injection, or IVF, for IVF cases is 18 to 20 hours post insemination. And in terms of the timing of the PM breakdown, the range is between 18 to 13 hours after insemination injection, but generally it occurs 22 to 25 hours of this procedure. So the point that I want to bring out here is that the range of this procedure are pretty wide, and our fertilization check is actually within a short span of time, which is just 2 hours, within 2 hours, which I understand majority of these 2 hours you will be able to assess the fertilization correctly. But there are some instances where if the PM was formed early or too late, you might actually assess the fertilization incorrectly. So whenever you see an abnormal fertilized zygote, the type PN formation and syngamy timing should be put into consideration before discarding it, or choose not to using it. So there are times where you have patients do not have any normally fertilized blastocysts for transfer, but their abnormal fertilized blastocysts develop even way better than the normal fertilized blastocysts. And there are several studies have shown successful pregnancy and live birth from this blastocyst. So for this kind of patient, how can we actually help them? So can we actually use this abnormal fertilized embryo to transfer instead? So in order to find the answers for this question, we actually have conducted a retrospective study to assess the chromosome and protein status of the blastocyst from this abnormal fertilized zygote, and we also assess the corresponding clinical outcome after embryo transfer. So this study was conducted between July 2020 to December 2023. A total of 131 patients were recruited in this study. We were able to retrieve 2016 mature oocyte. All these oocyte had ICSI done, and we performed the fertilization check 16 to 18 hours after ICSI. And these eggs are cultured in time-lapse incubator up to blastocyst stage. So these are some of the images that we obtained from the time-lapse imaging. So this is the picture of a 1 PM blastocyst, and this is 2.1 PN. In terms of this 2.x PN blastocyst, we have up to 2.3 PN observed. And in terms of equal size PN, we have up to 4 PN observed. So these are some of the examples. And as you culture the blastocysts, as you can see here, these blastocysts are very good in terms of the quality. And you probably wouldn't believe that these are actually from this abnormal fertilized zygote. So among this 2,000, about 2,000 mature oocyte, we managed to get about 1,348 normally fertilized zygote and 273 abnormally fertilized zygote. And among this 200 plus blastocysts, we have at least 50, we have about 50 blastocysts achieve at least fair graded blastocysts from 1 PN group, and 90 of them had at least fair graded blastocysts for more than 2 PN group respectively. So in terms of this blastocyst, we actually performed a blastocyst biopsy. After the biopsy, the blastocyst was then frozen using vitrification. The biopsy sample were then subjected to a method of whole genome amplification called multiple displacement amplification. And we use this DNA product to perform PGTA testing. And if the embryos were tested euploid or mosaic, they are eligible for the subsequent testing. The results were reported to the patient, and we had a counseling with the patient. And if the patients wanted to have subsequent testing, they are consented. And the subsequent test here is biparental and protein assessment. So how do we do this test is we look at 24 STR markers from the samples between the parents and the embryo. So to do this, we have to collect blood samples from the father and the mother. And we will look at the STR markers between this blood sample. And we will also perform the assessment on the embryo DNA product as well. And by having these 3 STR markers, we can compare with each other, just like how it is shown in this picture. This is one example that we have. And from here, we can actually assess the protein status of the embryo. So embryos that are assessed as diploid, they can actually have frozen embryo transfer. And if the patient got a pregnancy from this kind of embryo, we will actually, after that, did an amniocentesis to confirm the prodrug status of the fetus. So here I would like to share the results of the study. So I will first begin with the distribution of this more than 2 pm blastocysts. As you can see from the chart here, we have a majority of the blastocysts from 3 pm blastocysts and quite a number from 2.1 pm. And we have very small percentages of blastocysts from 4 pm, 2.2 pm, and 2.3 pm. In terms of the chromosomal status of this blastocyst, as you can see from this chart, the euploidy rate for 1 pm blastocyst is significantly higher compared to more than 2 pm. There is no statistical significance between the aneuploidy rates between these two groups. And interestingly, the more than 2 pm groups has a significantly higher MSART rate compared to the 1 pm group. So among the 1 pm blastocysts, there were 20 of them had biparental and ploidy testing. So among these 20, we have 15 euploids and 5 low-risk mosaic blastocysts. Out of these 15 euploids, we have tested 9 diploids and 6 haploids. So out of these 9 diploids, 3 of the patients wanted to have an embryo transfer, and we were able to achieve 2 live births and 1 unsuccessful pregnancy. The 2 live births here, when we do the antenatal assessment using amniocentesis, both of these fetus were confirmed to be a diploid. And for the low-risk mosaic, we are able to achieve 1 diploid and 4 haploids, but there's no embryo transfer yet to be done on this diploid blastocyst. In terms of the more than 2 pm group, we have 7 blastocysts that had testing. So out of these 7, we have 4 euploids, 2 low-risk mosaic, and 1 high-risk mosaic. And interestingly, all the 4 euploids here, they were all tested as diploid. 2 of the patients agreed to have embryo transfer, but we did not get any successful live birth here. We have 1 miscarriage and 1 no pregnancy. And when we trace back the blastocysts, these 2 blastocysts are from 3 pm zygote. In terms of the low-risk mosaic, we have 1 diploid and 1 triploid. Again, this diploid embryo is not transferred yet. And for high-risk, for that 1 high-risk mosaic that we have, it is tested as diploid, and the patient had the embryo transfer. Again, we do not get any successful pregnancy, and this is from a 4 pm zygote. So next, let's look at some of the discussion of our results. So if you look at the data here, we observed that about half of the 1 pm blastocysts were actually diploid, and about 3/4 of the more than 2 pm were actually diploid. But we believe that the sample size here are too small to confirm this distribution of the ploidy status among the general blastocysts that we have. So we need further studies to confirm on this. But interestingly, we can see quite a big number of them are actually diploid from more than 2 pm. So in terms of the higher euploidy rates in 1 pm blastocysts, we believe that this is the case where you have 2 pm formed within 1 large pm that we have experienced previously. There are certain instances that parthenogenetic oocyte activation, which is the self-activation of the oocyte, occurs. And if this kind of oocyte were able to reach blastocyst stage, and if you do PGTA testing, because of the normalization of the haploid cells of chromosome towards the normal reference, we were unable to differentiate between the ploidy status between 1 pm and 2 pm blastocysts. And also PGTA using NGS here applies shallow sequencing. So this is actually insufficient for ploidy assessment. So we can't use this NGS PGTA to confirm the ploidy status. In the findings of having high mosaic rate in more than 2 pm blastocysts, the origin of mosaicism is unclear, but Bielanska and colleague here has suggested 2 hypotheses where they believe that this could be part of the post-meiotic errors of the blastocyst, or it could be a phenomenon of the trophoblast differentiation. In the cases of micronuclei, which blastocysts that are from 2.x pm, which they have small PNs formed around them, most of the cases, this small PN contains lagging chromosome, which means these chromosomes are not incorporated during the cell division or cell cycle. So they were left behind and they are susceptible to severe DNA damage and improper segregation. So this can actually contribute to the mosaic profile in this kind of in this more than 2 p.m. blastocysts. And in terms of the euploidy and diploidy in 3 p.m. blastocysts, Grau et al. Actually suggested a self-correction mechanism hypothesis, where he hypothesized that with the presence of the paternal pronuclei in the embryo, it can help to self-correct those triploid blastocysts into diploid. That means this 3 p.m. with the help of this paternal pronuclei, one of the maternal PN can be somehow discarded and turns into a diploid, or sorry, self-corrected into a diploid. And another group here also suggested, have also hypothesized that among these 3 PN, they have the ability to extrude and subsequently degenerate one of the haploid nucleus. That means in this 3 PN zygote, the embryo has the capability to degenerate one of the haploid nucleus and sort of self-correct it to diploid. But again, this hypothesis that was suggested by this group, I believe that it requires further studies to confirm. So hopefully in the future, there will be more studies we were able to confirm whether the possibility of self-correction on such blastocysts is possible or not. And in the event, in the case of 1 p.m. blastocyst, I believe most of us has heard or being told that if you have a presence of chromosome Y in this blastocyst, we actually can assume that this 1 p.m. blastocyst had a normal fertilization. But Capabo and the colleagues actually had done a study, and he finds that this is not the case anymore because it actually contains all possible ploidy configuration, including a triploid profile. So this is what they have found. So because of this, I believe that we cannot assume that having a chromosome Y is a normal fertilized for this kind of blastocyst. So we actually recommend to perform ploidy assessment on 1 p.m. blastocyst, even though you have a chromosome Y presence. So it's better to test before you use it for transfer. So that is all about the retrospective study. I will then go into an introduction of a polyploidy assessment panel, where you can use this panel to assess the ploidy status of the blastocyst. And the principle of this ploidy assessment uses molecular methods such as SNP amplicons, triallelic microhaplotype size, and also allele frequency distribution. So in terms of this panel, we were able to participate in a pilot study where we had first hands-on on this polyploidy assessment panel. This is a summary of a single run that we had. So by running this panel, each of the rows here are representing one blastocyst. So if you have this blastocyst tested in this panel, they were able to tell you the ploidy status shown here. So we actually cross-check with the fertilization check, and we can observe from here that majority of them are actually concordance in terms of the numbers of PN observed during fertilization check. But we have a few of discordant results here. For example, you have here 1 PN that was assessed as diploid and a few 3 PN here assessed as diploid. So this panel is still, I would say, requires further validation, and I will share with you some of the validation steps that we use to confirm the results. So in order to look at the to validate the results, we have to look at the raw data. So if you go into the raw data and you look at their distribution peak, and if the profile shows you a graph like this, you have two peaks. This is representing a triploid profile. So if you see this graph, then you can sort of like assess that blastocyst is a triploid blastocyst. If you see a graph that shows like a normal distribution curve like this is a diploid profile. And if you see profile like there's nothing in between, but you have two bar charts at the edges of this graph, this is a haploid profile for that blastocyst. So you have to further confirm with this kind of distribution peak. And another parameters that we need to assess is the heterozygosity frequency, which is shown over here. So here, each of the rows here are the SNP amplicons that were used. So in order to assess the blastocyst is diploid, you should get majority of the frequency at 50 to 100%. If you've seen like the frequency, majority of them are at 30% or 60%, this is a triploid profile. And if you see 0 and 100%, this is likely to be a haploid profile of the blastocyst. So, in conclusion, abnormal fertilization does lead to significant numbers of euploid embryos with confirmed diploidy and biparental origin. And transferring this blastocyst does shows potential for successful embryo implantation and healthy levels in IVF. And in the event if the patient does not have any usable blastocyst from normal fertilized zygote, they may consider to use blastocyst from abnormal fertilization, but provided that this kind of blastocyst were confirmed in terms of their early status and also biparental origin. With that, I would like to end my presentation. Thank you very much.
Thank you very much. Thank you very much, Mr. Yeah. Yes, we do have some questions now coming in through.
Okay.
I would like to read to you the first question. I'm not sure you can see it also.
Okay.
First question is from Anonymous. For 1PN mechanism, do we able to differentiate, or can we able to differentiate this whether this PN is from sperm or oocytes?
Okay, so if we just look at the mechanism that we have explained, there are two types. But if we assess the blastocyst fertilization using microscope, we were unable to assess it. But if you actually use the biparental testing or the body assessment, because we have the STR markers from the parents, so if the 1PN blastocysts are truly from having only haploid sets of chromosome, it will show the same STR profile as one of the parents. So the answer is yes, we can actually differentiate whether is it from father from sperm in the case of father or oocyte for the case of mother.
Another question here. Hi, let's say the results for polyploidy assessment inform that no results can be seen. What's your opinion regarding this embryo?
So the question here is that no result can be seen here. There's many factors. Sometimes it could be that your source of your DNA was not good in quality. That means when you perform the biopsy or whichever sample that you use, the collection method was probably done incorrectly. So in order to counter this, I would say one of the way is you can actually try. The best way is actually to recollect the sample again with a proper technique. You could try to rerun the sample again, but I would expect the same kind of results to appear. So I would actually prefer a recollection of the sample would better confirm on the results.
But another biopsy would probably be the best option. But it would probably damage the embryos more.
So you have to look at the quality of the blastocyst. So if the quality of the blastocyst, for example, having A-graded TE cells, then I think taking another biopsy will not probably damage the blastocyst. But my another concern is because if you actually freeze the blastocyst already, in order to recollect the samples, you need to thaw again and do the biopsy and then refreeze it again. So you need to have a good vitrification system or freezing system in order to do that. So if the freezing system is not that good, then you can probably try to reflect this to your patient. If let's say they think that they do not want to do further testing, then we should respect their decision. And if they wants to do further testing, and at least we can tell them what are the risks that could happen on the blastocyst, for example, rebiopsy and re-thawing and refreezing. So if they can accept, then we can actually proceed.
Coming to that, this is my own question. Would you biopsy a C blastocyst?
C blastocyst, you mean for testing in general or?
Or
Yeah,
rebiopsy? Yeah.
So we do not test on C graded, but we actually do have some discussion before making such conclusion. So if let's say the C might actually seems to have enough cells for biopsy, then we will try to not take so many cells. So hopefully we can at least still get some result without damaging the blastocyst that much. Yeah.
Okay, my next question is, can PGTA use to assess polyploidy?
Okay, so the answer is yes and no. So yes, for the case for polyploidy, for example, triploidy, but having XXY. So as I mentioned just now, because generally the PGTA testing, the testing method is itself using normalization of the references. So if you have a chromosome Y, for example, the XXY, for triploidy cases, it actually somehow disrupt the normalization. So you can actually see some differences in the PGTA profile. So if you look at the profile, you will see that the X will be somewhat like at 50% mosaic and Y will also at somewhat 50% mosaic. So with that profile is quite prominent or quite significant to sort of like conclude it as a triploid XXY. But if I ever see such result, I will actually always look back to the numbers of PN. So if it correlates, then we can sort of like, conclude that the PGTA can use for testing on this kind of blastocyst. But then again, this is just for XXY. But if it's triple X, you can't distinguish it. So it's actually better to use other methods such as the bioparental and protein assessment.
Okay. Another question here, can sperm crushing technique related to 1PN formation?
Okay, so sperm crushing, I will assume that you will only crush on the tail side. So if it only crush on the tail, I don't think that can cause. As I have described just now, this formation of 1PN usually is because you inject wrongly where within the oocyte, the spinal fibers, you eject at the spinal fibers position. So that can actually interrupt the fertilization process and causing 1PN blastocyst to be formed. But in terms of if it's just the sperm tail, I think that is not an issue.
So this my own question now. If you use piezo ICSI, would that reduce the chance?
So piezo-ICSI, I would say again, because piezo-ICSI, they're using this piezoelectric effect to sort of like damage the oocyte at the minimal stage. So based on this theory, I believe that it can actually reduce the formation of such 1PN formation. So I think generally the simple answer would be yes, but I did not did any studies on this, so I can't confirm this, but based on this theory, it could be a yes for me.
Yeah, theoretically. That's okay. Thank you very much. And my next question, for centers that do not have PGT services, do you recommend to freeze or transfer 1PN and multiple PN blastocysts?
Okay, so for this case, usually we do not actually in default do freezing or testing on 1PN and multiple PN blastocysts. We will actually discuss with the patient. So we will always get the patient's opinion on this. So if the patient thinks that they will or probably in the future will use this kind of blastocyst, then we will respect that decision and we will freeze such blastocyst. So again, we have to always come back to the patient because this is their IVF cycle and this is what they want to achieve. So with a proper counseling and proper explanation to them, and they can actually make informed decision. So this is what is important in this. Yeah. So we don't do it in default, but we always have to go back to the patient.
Okay, but next question is up to which grade of blastocyst normally advised to biopsy? Lebih kurang the same question that I asked, but a continuation of this, did you all have biopsy for BC blastocyst or any euploid blastocyst for this grade of blastocyst? If you biopsy 4BC, any euploid from grades.
Okay, so there are two questions here. I will answer the first one
Do
first.
you biopsy which grade of
Oh,
biopsy
sorry.
you advise to biopsy? Okay, we answer the first one first. Which grade
Alright,
of
so
biopsy
the first one.
advise for biopsy?
Okay, so in general, we will the Gardner's guided Gardner system recommends at least BB grade, which means B for TE and B for ICM. But again, we will also look at some of it. This is just in general. So the second question is, do you all have biopsy for 4BC processes? The answer is yes, we actually did. After discussion with the embryologist. And the third question is, any euploid out of this grade of processes? The answer is also yes. So we are able to achieve to get euploid processes from these 4BC processes. But then again, because the T cells is already C graded and you have already taken some cells out, so we believe that there might be some impact on the implantation for such processes, even though it has been tested euploid. So we would expect that although you have tested is euploid, but the implantation for such processes may not be as good as other 4BB, at least 4BB processes. I mean BB grade processes. So this is something that we have to look into it as well. Yeah.
I have a question here. What are the patient's responses towards this biparental and ploidy testing?
Okay, so generally, I would say there are three types of responses. The first one is, of course, they agree to do with it. Secondly, is some of the cases where patient actually had normally fertilized processes that are euploid, but they have one or two abnormal fertilized processes. So this kind of patient, usually they do not want to do testing on this abnormal fertilized processes because they have so many euploid 2PM processes can be transferred. But I have a few patients who just out of curiosity wanted to know the status of this processes. They went and agreed to do the testing. So we will also help the patients to do this testing as well. The other side of the spectrum will be the patient do not want to risk of using these processes. They choose to start a new IVF instead to get euploid processes from 2PM embryo. So that is the second one. And also because that we need blood samples from the parents for this testing. So we have some patients from overseas. So because of logistic inconvenience, they actually decided not to do this testing. So they actually choose to start a new IVF cycle instead, which is much more convenient for them. So generally, these are the responses that we have from our patients.
What are the risks of them getting not another ploidy if they start a second cycle?
So we will assess the maternal age of the patient. If they are still young, we will expect them to have a higher chance of having euploid processes. But for example, if the patient is like 40 years old or 38 above, then probably they might need to go for a few IVF cycles to get an euploid processes. So we will have to feedback this to the patient and counsel them properly. And if they are okay with having to go for another few IVF cycles, then we will respect that decision. But we also have some patients do not want to go for another IVF cycle, but they went and test this abnormal fertilized processes. But some of them unfortunately do not have any diploid processes for transfer. So then because of this, they choose to do another IVF cycle instead.
There's another question here. What is the percentage of abnormal results from immunosynthesis among these transferred embryos resulting in pregnancy?
So in terms of our study, we only have two cases, and two of them were actually diploid. I would expect that if let's say the embryos are truly abnormal fertilized, they are unlikely will be able to reach up to 14 weeks of pregnancy. Usually they might have an early miscarriage. Yeah. So usually if they were able to achieve at least about 16 weeks of pregnancy, there are a high chance that they are actually diploid. But there are also a small percentage that it could be a molar pregnancy or it could be an abnormal fetal growth, that we have not encountered it, but we believe that there is a possibility. So that is why the amniocentesis testing is so important here. We have to make sure that the fetus is having the correct set of chromosomes.
So the question here, how do you counsel patients with high mosaic but diploid blastocyst? Yeah, that means abnormal PN. Do you encourage them to transfer? What are important things to be highlighted during counseling?
Okay, so in terms of high mosaic here, I guess what it means is high risk mosaic.
Yeah.
So but diploid blastocyst with abnormal PN. Okay, so I will counsel the patient that in terms of the fertilization check, we do see abnormal PN, as in abnormal numbers of PN, but this has been confirmed with the biparental testing. So although we see at maybe 3 PNs or 1 PN, but because the biparental testing already confirmed that this is a diploid, that means it is sort of like a normal fertilized blastocyst already. So you can treat it like a normal fertilized blastocyst, but then again, because this blastocyst is high risk mosaic, so we have to counsel them in terms of what are the possible outcome of transferring high risk mosaic blastocyst. For example, the chances of miscarriage and implantation failure is pretty high here. Also, the chances of unsuccessful pregnancy also is high. So if they choose to transfer this blastocyst, again, we have to make sure that they had amniocentesis or any form of prenatal testing done to ensure that the fetus had the normal sets of chromosome. And if the patient, after listening to all this counseling and they feel okay to transfer, then we will respect the decision. If they do not want to transfer, then we will also have to agree with them.
Okay, this question comes saying, is there a possibility that a patient may experience a significant number of abnormal fertilization due to poor egg quality?
So significant number of abnormal fertilization due to poor egg quality. So
In the egg this time.
yeah, so it's in the egg this time. So we've seen many kinds of patients here. Some of the poor eggs quality, majority of them are, I would say, they probably were not able to reach fertilization. Or in terms of fertilization, we do see some abnormal fertilization, but not in the sense of a lot. Like we do see a number, but not a lot. So yeah, these are some of the experience that we had. But having having abnormal numbers of PN in a batch of eggs does signify something, but we have to do further investigation to confirm on this.
Got one question here. How does time-lapse monitoring plays a role in abnormal fertilization assessment, in your opinion?
Okay, so this is a very good question. So because I've mentioned just now that the timing of PN formation and PN breakdowns differs a lot, like it ranges in a big range. So having a time-lapse monitoring system, we will not need to worry that we might miss some of the processes. So we were able to assess the embryo from the PN formation up to syngamy, up to disappearing, and up to cell division. So that actually helped us to confirm on the assessment of the fertilization. So with the help of time-lapse monitoring system, compared to if during the time that we do not have time-lapse monitoring system, we have a great numbers of 1 PN, 3 PN embryos that are greatly reduced during the assessment. And also another spectrum will be 0 PM blastocysts are also greatly reduced during the assessment of the fertilization. So I believe that time-lapse monitoring system here helps a lot in terms of assess on the fertilization of the zygote. So I would recommend to have one at least instead to confirm on the assessment.
It does really help a lot.
Yeah.
Good. Those may be a food of thought for those centers who may not have time-lapse yet. I got one last question here. Can fish, I don't know who does fish anymore. But can fish be used to assess the ploidy status of those abnormal fertilized embryos?
Yeah, okay. So probably I would believe that most of the centers now do not do fish anymore.
I
But
think the
to
younger
answer,
embryologists also do not know what is fish.
yeah, probably yeah, it's too old for them to know. So, but then again, maybe talk about the history of body assessment. The first molecular method that was used is actually fish.
Yes.
So fish is fluorescent in situ hybridization, where they use fluorescent probe to stain on the chromosome to look at the numbers of chromosome in the embryo. So during, I would say probably 20, 30 years ago, they actually used fish to look at how many sets of chromosome they have, but only on particular chromosome. So for example, 13, 18, 21, X and Y. So if they see like 3 chromosome 13 or 3, 18 and 3, 21 at the same time, then they can sort of like suspect that this is probably a 3PM bustrosis, a triploid bustrosis. But the limitation here is that they only assess 5 chromosomes, so the other chromosomes are not assessed, so
Yeah.
you can't really tell. Yeah, so that's why it is sort of like has been not used anymore. So people are now using uh, a better molecular system instead, such as NGS and RACG. Yeah.
Good. Yes, definitely. Uh, I hope everyone has learned quite a lot. I have definitely learned quite a lot tonight. And I would like to thank Mr. Stephen for a very insightful presentation today. We're still waiting for some questions, but I don't see any questions coming through. So looking at the time, we are reached almost 8:53. So since we don't have any more questions coming through, we also like to uh, extend our special appreciation to our co-organizer, Alpha IVF Women Specialist, and a helpful thank you to all of you for joining us. Please remember to complete the post-webinar survey once we wrap up. Any last words from Mr. Stephen before we close the webinar?
No, I shouldn't bother their time to watch Korean drama or football match now, so we should let them go.
Thank you very much. We also value very much your feedback and your questions. So we look forward to seeing you in our future events. Thank you very much, and please remember we have our congress at the beginning of October in 2024, 5th and 6th October 2024, and do register for that. With that, I thank you and I bid everyone good night. Thank you. Assalamualaikum.
Bye.